Well, thanks everybody. We're going to go ahead and get back started again. And we're going to spend a little bit of time learning about something that I'm totally confused about, which is really exciting because I still live in the RSN world, even though I know the RSN world doesn't exist anymore. So now we've got an opportunity. Charisse Pope and Joe Beckett are here from the Spokane County Regional Behavioral Health Organization, and they're going to help try to walk us through the transition that has been taking place not only in our region but around the state when it comes to how those services are delivered.
I'm going to go old school today.
Perfect.
How about that? Well, thank you. Good afternoon. It's wonderful to be here. I have to say I was in a training on Tuesday over in Olympia, and it was a full-day training, and I've learned more this afternoon than I did all day. So thank you very much. That was really nice to come and get so much information. So as Ed was saying, April 1st, just a month ago, 2 months ago, we had a significant change in behavioral health across the state of Washington. So if you felt the earth move, that was it. And it's true. Prior to April 1st, we had RSNs, or Regional Support Networks, which is probably what most of you are familiar with. So I'm going to take a step back, and 2014, the legislative session of 2014, that is when the legislators of Washington State passed Substitute Senate Bill 6312. And I probably should have that tattooed someplace because it's the day that all of our lives changed. So prior to the passing of Substitute Senate Bill 6312 and its subsequent implementation April 1st of just this year, across the state of Washington we had 12 RSNs who provided mental health services primarily for Medicaid and low-income individuals. We had 39 counties who provided outpatient substance use disorder or chemical dependency treatment services. And we had over 40, I think it was 43 chemical dependency or substance use disorder inpatient facilities across the Washington state who all contracted directly with DBHR to provide those services. So then 6312 passes and two things happen. One, the administration for those three things, so mental health, chemical dependency outpatient, and chemical dependency inpatient, all falls under one behavioral health organization. So you can see the administrative efficiencies there and part of the reason they passed 6312. The second piece, though, is quite important, probably for you folks, is that it also mandates that in 2020, the state of Washington moved to what they call full integration. So that's not only behavioral health, but that's physical health as well. And we have, I'm going to jump slides here, but I'll come back here and show something to you. I'm going to get my little pointer here. So this, in this region here where you see Clark County and Spokane County, part of 6312 was that if regions or counties wanted to become what they called early adopters, and some of you may have heard that term, early adopters, they could. And that meant that they're gonna skip the behavioral health option and they're going to move to full integration. So Clark and Spokane County there have actually, as of April 1st, they have full integration. And so that looks a little bit different in that area, not only because of the full integration piece, but because the state of Washington put those services out to bid. And so Molina and CHPW are the two Medicaid insurance plans that submitted bids and were the winning applicants, if you will, to provide full continuum, full services in that area. I'm going to go back here. So the BHOs are responsible. They take on full risk and liability for the individuals in their area, and that includes mental health and behavioral health. In order to become a BHO, and this kind of goes back to the RSN system, the counties had the right of first refusal. So the counties could say, yeah, we want to become a BHO, or we're interested in becoming a BHO, or they could say no, like Clark and Skamania County. So it really was the counties were given the right of first refusal in that process. This is primarily Medicaid and low-income individuals. These are not services for the commercial insurance plan. And the last bullet here, and I'm going to let you just take a peek at that real quick, and then I'm going to jump to the next slide. Because the key piece in our area that some of you may remember is Grant County. Grant County, previously to April 1st, was part of our RSN. But with the change to the BHO, Grant County actually joined the, let me go back. They never allow me to have these at work. So if I just stand up here and play, that's probably it's just my own fun and games here. But Grant County was able to join and did join Chelan Douglas there. You're also, for those of you who are familiar with RSNs, you're going to notice some changes in the Grays Harbor, Pacific. This area here all became one RSN. And the rest primarily remained the same with the exception of here that we talked about, or the Clark area there. But for the Okanagan, for those counties that remain with us, Okanagan, Ferry, Stevens, Pend Oreille, Lincoln, and we actually have Adams County in the house, which is wonderful. Those counties remained with us. They were with us with the RSN, and they remain with us under the behavioral health option. All of those counties have behavioral health centers that do not only mental health, but also substance use disorder outpatient. And so what do we provide? We provide all of the mental health services that all of you are familiar with or may have some experience with. But we also, again, kind of going back to the beginning, we also provide substance use disorder outpatient, and we contract with substance use inpatient to provide the members in our area a full network of services. We really had some core values, if you will, or core foundation pieces that we wanted to maintain. Our leadership has always emphasized keep in their community. So we contracted with those agencies and those providers in our regional service area, and that was a key piece. We have over 45 contractors or providers who are there to provide services for our Medicaid and low-income individuals. And I'm going to have Joe Beckett come up, and he's, because you folks are primarily interested in going in and out. Is that okay? Because I know you folks are primarily interested in mental health. I think that's the theme of the day, and so Mr. Beckett's going to talk about our mental health services in our regional service area.
I don't think for the outsider, not so sure too much has changed for mental health services in regards to how to access them. Crisis services are for non-Medicaid, Medicaid, so they're provided 24/7. Frontier Behavioral Health primarily provides them. We have involuntary DMHPs that go out on site with law enforcement or show up at the ERs. Much of that's been explained by Tamara. Stabilization services, so we have one 16-bed stabilization. That's a 24-hour facility where someone can go voluntarily. That does require that they have their medications with them. Some of those people are co-occurring people, need some time to settle down before they return back home or return to where they were before. We have two evaluation and treatment centers that are two 16-bed facilities, Kalispell and Foothills, that are run by Frontier Behavioral Health that accept both involuntary and voluntary clients as well. We have a proposed 16-bed evaluation and treatment facility that's hopefully going into Colville in the next year that will help some of the rural communities and relieve that pressure. We have detox and sobering services. We have the sobering van that goes out throughout the community, in response to police, response to anyone who has an intoxicated individual to bring them into sobering. Sobering is a 12-hour service. So if they're within 12 hours, they want to move up, they have priority for our detox services. In our detox services, we also have a dual diagnosis type program as well. One of the latest things that have taken place that I think is pretty cool when you talk about how good a partner of Providence is in the community, we suggested that we have a chemical dependency professional available for the emergency department at Sacred Heart. So anytime anyone comes in that's intoxicated or under the influence of drugs, we have on-call. Right now, someone walks up the street and meets with the individual. As a result of that program, we've placed over 600 individuals into treatment directly from the emergency department to try to keep them from to get them the services they need, as well as to keep them from, entering sometimes into the mental health system as, they get more hopeless with their addiction. So that's been a very integral program, which I think is family, and they're both talking to Valley and Deaconess as well, as trying to divert the people, get them situated, meet with a chemical dependency professional right away. We have residential facilities, so we have various group homes throughout with various levels of care throughout the community, so people are placed in those facilities. Carlisle, people are familiar with Carlisle, Sunshine. I believe we have 9 group homes throughout the community, so they're everything from full-bore psychiatrists on duty to a nurse to more of a less structured program, and the idea is to try to transition those people back into the community as soon as possible. We have methadone and Suboxone with the health district. That's expanding quite a bit. So they're looking into grants and expanding their services as well. Those individuals are all usually involved in some level of treatment throughout the community. 2 years ago, we started co-occurring for mental health and substance abuse. What happened was we recognized that there were individuals that required that service. 3 substance abuse providers came in that got their mental health license. They came in with those community-based services. So the trend, I feel, in mental health and substance abuse is less bricks and mortar or more, feet on the streets. They're the type of service that will go meet with the individual if the individual's in crisis. They'll also go meet with the individual if the individual's in a facility such as Eastern State Hospital or Sacred Heart, try to ensure discharge planning and continued care. The Involuntary Treatment Act was pretty well explained earlier, but again, that system is totally in crisis throughout the state. The people that are presenting today, we've all sat in meetings with impossible choices, to be honest with you, that affect individuals' lives on a regular basis, and it's been a pretty interesting time over the last few months. But again, it is an overwhelmed system. I mean, at any given time, we have individuals, probably 15 to 20 individuals that have already been detained that are looking for a bed, inpatient bed, and we have moved to a system where we're calling throughout the state for available beds to try to place that individual. Currently, we're also negotiating with the courts because Valley and Holy Family and Deaconess do not have a court in-house like Sacred Heart, so we're looking at a traveling court. We've been negotiating, and it's going to happen, but it's taken time. Again, as we look at how to pay for it and what's involved with that. We also have looked at, we got a grant for possible, when we're talking about the not guilty by reason of insanity, we have a grant to try to work on outpatient competency or diverting individuals, because right now someone who is declared incompetent through the courts, the only option is to go to inpatient. We're trying to glean some individuals who possibly could be more successful on an outpatient basis and not clog the system, resulting from this recent lawsuit. Behavioral health treatment, that's outpatient services, I'm assuming, throughout this. So we have probably, how many contractors, mental health? 45 total. So now the change in the system is the fact that everyone, inpatient chemical dependency, outpatient chemical dependency, and mental health are underneath the umbrella of the behavioral health organization. So we have really integrated those care. One of the big changes is that if a person used to go to an inpatient facility, they had to be discharged from the outpatient provider. Then when the person was ready to leave again, then they had to get another intake with another provider. What we've allowed now in this system is someone can stay in an outpatient, enrolled in an outpatient. That therapist can go see their client while they're in an inpatient facility to better enhance, treatment and better care. So it's pretty exciting in that regard. I think that will help the system and help the clients. So I've explained ENT facilities, and we have our substance abuse inpatient facilities. So the past year, as Charisse said, has been really putting together this whole package and how we're going to pay for it and what kind of diagnosis we've been going to treat and how's that going to be billed. And oh my gosh, it's been unbelievable here for that. So I don't know if you have any brief questions right now about what we offer, but I think from the outside, what we tried really hard to do is not make any changes apparent to the people who are accessing the services. So we still have first call for help. We still have the same way for anyone who wants to provide and access services. Hopefully it gets better as time goes on.
Thanks, Joe. Appreciate that. So we've gone through the kind of the how did we get here and the what do we provide, and so what was the ultimate purpose of the BHOs. And I kind of talked a little bit about this from the onset. There was just a lot of administrative efficiencies when you're talking about going from essentially 3 different systems to one entity who's overseeing the services. One of the things that we have emphasized and was part of 6312 also, or the intent of 6312 was to treat the whole person. And you certainly get a gist of that if you're looking at 2020 and full integration. I'm not sure what all of your where all of you folks come from or what you do, but if you get a chance to pull up Substitute Senate Bill 6312, I do think it's one of the more important pieces of legislation that we've passed in probably the last decade, especially for behavioral health services. So if you get a chance to pull that up, Google it, it'll show up. It's about 80, 90 pages. It's not the worst read you will ever have in your life, but it will certainly hopefully give you some insight towards where we are today, and it will certainly give you some insight into where the state legislation or the state legislatures want us to be in 2020. And obviously with the administrative unduplication, if you will, you're going to see financial resources more effectively managed through utilization management. And I'm just going to touch briefly on that because that was a huge change for our substance use disorder chemical dependency providers. Prior to April 1st, someone could walk into an outpatient clinic or even an inpatient center and say, I want help. I want to get services, and the clinician would hopefully see them and do an assessment and then recommend a level of care. And if they were Medicaid, great. If they were low income, depending on the financial resources of that county, they were more than likely put into services. Come April, that changed. So it's much more like what you folks are probably used to in regards to your health plans. If you have Premier, Group Health, Charisse, Blue Cross, whatever you have, there are certain services that you have to get approval for. You go see your primary care physician and they say, well, you need an ultrasound or you need an MRI, and depending on what your insurance plan is, they may have to seek prior approval. Well, that's essentially what has happened for chemical dependency or substance use disorders, the new term. So you hear me use it interchangeably because we're still used to CD, but it's actually substance use disorder now. That was a big change for our outpatient providers. It was a ginormous change for the inpatient providers of these services across the state, who not only took individuals who met financial eligibility, but then also had programs that many of you are probably familiar with that were, if you asked them, how long is your program, they would say, oh, 90 days, 60 days, 45 days. If you look at best practices, that is not indicative of best practice. And we did, as we were designing or implementing this behavioral health organization, or BHO, we did a couple of things. And one of those things was we hired national consultants and who specialized in substance use disorder treatment services and working with organizations such as ourselves across the nation. We had them come in, and they actually spent about a month with us. We got to the point where we're like, well, do we like these people, do we not? But no, they were very, very informative, and really what we wanted from them was a national perspective. We wanted to know, what is best practice? And we wanted to know, what are the national trends and why is something a national trend? And so they really helped us with our utilization management piece. So now when somebody goes into inpatient, they are authorized for an initial 15 days. And then at day 14, that counselor working with that individual has to do an assessment. Some of you are familiar with the language I'm going to use, the ASAM, patient placement criteria. If you're not, that's okay. It just means that counselor is talking with that individual, seeing where they're at, assessing where they're at, and getting an idea, okay, does this person need an additional 15 days? Or are they okay to go back to their community, engage in outpatient services, and receive services in their community and be at home? And so that's been a huge change for the inpatient providers, and it's not just our BHO that took a look at that. It's really was a statewide effort across all the BHOs. I personally think it will result in better care for the individual. Obviously, one of the indicators, or one of the things that we looked at in regards to best practice, was keeping people in their communities and keeping people close to home, close to their families. Everything that we read and studied indicated that is best practice. And so but that's been a big significant change across our system of care. So that's something that, if you haven't heard about it, you might hear about it, but that was one of the big changes, especially for the substance use disorder providers. The mental health providers, and we have a couple in the room who might raise their hand if I misspeak, but for them, the change to the BHO, the Behavioral Health Organization, at least for our mental health providers, has been fairly minimal and fairly non-impactive. It's primarily been our agencies, CD or substance use disorder providers, who have had to make big changes just within how they do their business. But we spent, Substitute Senate Bill 6312 passed in 2014. That was a long session, so it actually ended in June or July of that year. And the day it finished is the day we started working. And so one of the wonderful things that has happened in the year and a half up to implementation is that we had providers in the room. And we had meeting after meeting after meeting after meeting. And what was interesting is that I just assumed a lot of these providers knew each other. I assumed that our inpatient providers in Spokane County or in our region knew the outpatient providers who had been referring to them for 30, 40 years. They had never met. And so just to get them in the same room and speaking and continuing to have meetings and continuing to work out discharge planning and continuity of care and treatment planning has just been a wonderful process for both the providers, but ultimately the individuals. So with that, are there any questions that folks have of us? We're more than happy. Joe even plays banjo, and so if you have any requests, I think sing a tune or play a we've stumped you all and we've done our, okay. No. Thank you very much. It's been an honor. Thank you.
No. You guys are doing it all wrong. We're going to go back to my Boy Scout days. If you guys remember, a couple months ago, we did the watermelon cheer. Well, today we're going to do the clammy cheer. So instead of clapping like normal people, this is how the Boy Scouts do it. Come on, everybody, let's applause for our speakers. Not very loud, but it's much more fun when you're 8 people. All right, well, that's some great innovation, a lot of great change, and hopefully all of this is working towards a better system from a lot of great people in this room that are trying to work to make it better. And for you, we appreciate that, the work that you're doing. We're going to shift gears a little bit here, still within the mental health realm, and we're going to have Jan Dobbs, who is with Frontier Behavioral Health in Spokane, and she is going to talk about our Regional Behavioral Health Response Plan and a lot of the work that's been done on that, and some updates and some new things that really helps bring mental health providers to involved in our response systems.
Okay. Good afternoon, everyone. I'm Jan Dobbs, and I'm the Chief Operating Officer at Frontier Behavioral Health. And as you've heard from the presenters before me, Frontier Behavioral Health provides mental health services to individuals of all ages. In addition to that, we also provide services through our evaluation and treatment facility, in which we admit voluntary and involuntary individuals 18 and above. And then we have a stabilization unit where we can admit up to 16 people at any given time for a short period of stabilization. I was asked a few years ago if I would be interested in joining the Healthcare Coalition. And without knowing very much about it, one of the first things they asked me to do was to be involved in the creation of the Behavioral Health Disaster Response Plan. And not knowing what any of this meant, I agreed to do it. And the first thing I did was I got together a group of stakeholders, and Sharon in the back there was one of the stakeholders who was involved in this project with me. And the idea was, as a system of care within the region, how could we put together a plan that we could get out to all of our partners and have some level of agreement on how we would respond if a disaster did occur, and mental health or substance use services was needed for the individuals that were involved in any type of event. And so Sharon and I and the other members, we, of course, went to the internet and started to look at what do people have out there. And there wasn't a lot. Surprisingly, back then, behavioral health response in a disaster was not a priority, and probably did not become a priority until some of the disasters occurred, like Katrina. And then that started to get people's attention. And they started to think about, what do we do with people who have a mental illness or a substance use disorder? So there wasn't much out there, but whatever we found, know that we stole and created and tried to adapt it to our own community. And so this is the plan that we've come up with. How many of you have even seen it? Okay, great. Oh. Okay, then I'll tell you what it's all about. I'm not going to go through a lot of this in the beginning because I think that you probably understand the principles of the plan. If there were to be a disaster, who would you contact? How would you activate the mental health or the behavioral health system of care? And what resources are available within your community? Well, what we did was we looked at what kind of authority do we have to even have this plan, and you can see up there it talks about the local emergency management. And then what we decided was we really needed a single point of contact to activate this. And of course, we went to the BHO. Frontier Behavioral Health contracts with the BHO for the mental health services that we provide and for our inpatient units as well, and medication services that are provided. BHO contracts with practically every mental health provider in our community, as well as every substance use provider. So because we are under contract with them, if they call us and say, hey, we need you to do X, Y, and Z, we're going to be responsive to them. Every single community within the state of Washington has a BHO. So every county has a BHO that they are responsive to if they provide mental health or substance use services. So it was really logical to use them as the single point of contact. Emergency management has one phone number to call. And that one phone number, 24/7, will get them to the administrator at the BHO. Now, when the information is shared with the BHO about what the event is and what kind of resources are needed, what the BHO will do is they'll look at this response level. If it is a level 4 response, then they're probably going to call someone like Frontier. Remember, they have a lot of providers. We're one of them. They could call us and say, hey, there's an event going on. Can we take 5 of your staff to respond to this event? Then they could call Lutheran Community Services and say, hey, we want 3 from you. And they could call YFA Connections, a substance use disorder program, and say, can you give us 5 people as well? So depending on what the event is, that will determine what level of response they're going to be asking for. So at the lowest level, it'll be people who are at work, and they have all these providers, and they can select which providers they want to have involved and how many staff do they need to help with the event. If it was a level 3 disaster, then they're going to go beyond the people at work, and they may ask us, can you bring in some of your staff who are not currently on site? Because we operate facilities, we have staff that work 7 days a week, and they work different shifts. So during that event, they may not be at work, but they may be someone we could draw upon. If it's a level 2 disaster, then that expands it a little more, where it's not just the people or the agencies that the BHO contracts with, but then it may be private practitioners. They may reach out to Providence and say, hey, we've got this going on and we could use some assistance here. And then a level 1 disaster, that's like all hands on deck. Whomever you have available, it doesn't really matter if you're with the BHO or not, doesn't matter if you're in private practice, we need you. We've got an event, and the response that's needed is pretty vast. You can see that what we would like to do is have our staff trained in psychological first aid. The one thing that we know about disaster response in terms of mental health is that that is not the time to try to do therapy. That is not the time to try to gather a bunch of people and do a group. What you're looking at is what is going on with that individual, and you're actually trying to triage them, because it doesn't make sense to provide a service to them at that time. Our medical director, Dr. Tran, was just back at the APA conference, and one of the speakers that they had was an expert in PTSD. And what he was telling all of those psychiatrists there was that what they've shown, they've done studies because of 9/11, and what they're showing is that people who received services, mental health services, as a result of a disaster felt that they were worse because they were re-traumatized by the treatment, by the questions, and by the processing of that information. So that's really interesting, but you could probably see how that would happen. And so Dr. Tran is going to share that information for me, because that may have an impact on what this might look like in the long run. So there are, psychological first aid. We encourage our staff to sign up with the Medical Reserve Corps. We ask them to take a look at the basic training on incident command so that they would understand the structure and how they fit within the structure and who does what. so that they have an idea of what is going on. You can see that, you know, if there's any opportunity for us to be involved in a tabletop exercise or an actual drill, we are always interested in participating, because still mental health and substance use providers are oftentimes forgotten. Everybody is involved in the tabletop exercise, the drill, but somehow mental health and substance does not come to the forefront. So it really is that constant reminder, what are you going to do with that person now? You know, what type of resource might they need? What kind of triaging needs to be done so that they know that there are resources out there should they need them? And then you can see on E the triage levels. In terms of the BHO, you know, they're going to be figuring out what type of staffing is needed to respond. So they will have their own set of information that they're using to triage who's going to respond, how many are going to respond, for what period of time, etc. And you can see the service delivery sites. The one thing about mental health and substance use providers is they're used to being mobile. So, you know, a lot of them are able to go out into the community and provide that service out in the community. It doesn't have to be an in-office type of thing. So that gives you a pretty quick overview of this. I think that the main things to remember is that there is a single point of contact. We try to make it as easy as possible. One number, one person. That individual then will get to their contracted providers to try to get the type of staff that's needed, the number of staff that are needed, and then dispatch those staff. Do you have any questions?